Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today we'll be discussing endometriosis. Endometriosis is a painful and debilitating disease that affects at least 1 in 10 women, yet it often goes undiagnosed or is misdiagnosed by physicians. Recent research points towards new ways to detect and treat the disease, potentially bringing relief to millions of patients around the world. To discuss this further, I'm delighted to welcome my guests. With us today are Dr. Christine Metz. She is a research scientist and a professor at the Feinstein Institute for Medical Research. We also have Dr. Carmen Rodriguez, who is a clinical assistant professor of obstetrics and gynecology at the Zucker School of Medicine at Hofstra Northwell. And I'm also especially delighted to welcome a patient of Dr. Rodriguez, Allison Rodriguez, no relation, who is under the care of Dr. Rodriguez for endometriosis. Welcome all of you to Well Said.
Thanks. We're delighted to be here.
So, I've made it my practice over the last couple of years to start each of my shows by asking people how they've been managing through the extraordinary experience of a global pandemic. So since we're still in the thick of it here, it seems an appropriate way to start this conversation as well. So how you all doing? Carmen, you're the clinician here. Why don't you take that first?
I think it was an eye-opening, soul-searching experience. I feel that I've always known to be resilient, but the resilience went up like 1,000 times more. And I feel that we all connected and we're able to help each other. So definitely a lot of learning through the process.
Yes. Christine, you were about to say something?
We're just having our normal day-to-day activities and using a lot more online options, which has been, doable in research. And we just try to do day by day.
And Allison, how about you?
Well, it has been a learning experience. I work in the social services field, so I work directly with clients and have to do home visits. So it was very interesting to maneuver through the pandemic, how I would see clients who had COVID or needed some assistance. I learned a lot about myself.
Glad you all took a positive spin on what's been a sort of globally miserable experience. Let's get to the conversation at hand, which is endometriosis. So I'm going to start with Dr. Rodriguez. Why don't you tell us what endometriosis is?
Endometriosis is a disease that affects, like you said, many women. It happens due to the normal lining of the cavity of the uterus that is supposed to be part of what your menses come from. That lining ends up being outside of the uterus. And when it does that, it causes a lot of changes that cause inflammatory changes and painful menses as well as painful intercourse. It's a debilitating disease that can have from very minimal to severe.
So, Allison, how would you describe your experience with this illness?
I was first diagnosed by Dr. Rodriguez at the age of 21. Prior to that, I had no idea that I had endometriosis. Everyone just told me that the debilitating pain I had was normal. So it's been a journey, especially these last few years that she's been treating me, because it's surgery after surgery. You think you fix one thing and then there's something else that comes up.
So both of you mentioned the pain associated with endometriosis. Is that the principal symptom that women experience, or is there a kind of a broader set of symptoms that define this condition?
No, there are definitely other symptoms like infertility, painful, not only pain in general with the period, with sex, with period, without period, once it gets worse, but definitely infertility. And for patients as well, they may undergo depression, feel isolated. There are other symptoms that the disease can cause. And also, for some patients, it's not only limited to the pelvis, it can go to other areas of the body, causing other problems as well.
I quoted some figures in my brief intro about the frequency with which this occurs. Did that sound right to you? Is it really 1 in 10 women?
I believe so, but I feel like possibly it could be even more because a lot of women don't get diagnosed and also do not even come to doctors, or when they do go to doctors, they don't get diagnosed.
Christine?
I would agree with Carmen there that the estimates are about 1 in 10, but unfortunately, many people aren't diagnosed, so they don't get counted. And that includes teens and young adults. Even though the average age of diagnosis is like 29 or 30, that doesn't mean that young people aren't suffering with this disease.
You mentioned the age at which a diagnosis is made. So I'm going to ask you both how a diagnosis is made. So Allison said that she had cyclic pain associated with her menstrual cycle. Take us from there, Carmen. What do you do as a physician evaluating a woman complaining of menstrual pain, and how do you come to a diagnosis of endometriosis?
Okay, so someone can have pelvic pain for many reasons, and I feel like that's one of the reasons why a lot of patients don't get diagnosed early. You could have pelvic pain due to something with your bladder. You could have pelvic pain due to your intestines. You could have pelvic pain due to your period or endometriosis. You could have fibroids. There are other conditions that give you pelvic pain. So first you have to do a pelvic exam. You have to do a sonogram. But you go down the line, if all the studies that you do on a patient are negative, then you have to consider endometriosis, especially if they have pain with their menses. That's significantly. The standard for detecting endometriosis is a laparoscopic procedure where you actually get some of the lesions and you send them to be studied. And I think that's also part of the delay in the diagnosis.
And when you say laparoscopic procedure, you're talking about surgery.
Correct.
What does that entail?
That means the patient goes to sleep under general anesthesia. They have a small incision, usually in the umbilical area or the belly button, and 2 other small ports. It's visualized. It could be just diagnostic where you look. For endometriosis, you want to take a little piece of the lesions and send it to be studied. And then the patient usually goes home the same day.
I would imagine that a lot of people listening to this would think that that's kind of a brutal way to just make a diagnosis, right? I mean, we're not even getting to the point of treating it and you're already operating on somebody. Isn't there some sort of scan or blood test or imaging study that can be done short of poking a hole in somebody's abdomen?
You know, the major societies that have defined this condition have defined that definitive diagnosis requires analysis, pathological analysis of those lesions. So it's actually been defined by multiple societies as that. And MRI and ultrasound can be used to help detect it, but usually only for very large lesions. And then you're not even sure whether those lesions are actually endometriosis lesions or not.
I agree with Christine. And not only that, I've had plenty of patients with negative MRIs that when you do the laparoscopy, they do have lesions. So it is the only method that we have to actually look at patients with endometriosis, and it has a positive yield that is great, but it's not 100%.
Allison, did you have a diagnostic laparoscopy, a diagnostic procedure of the sort that Dr. Rodriguez is talking about?
Yeah, so prior to seeing Dr. Rodriguez for the first time, I had a CAT scan done, which reported possible endometriosis. And my first visit with her, I described my symptoms. I provided her the CAT scan, and we did a diagnostic laparoscopy.
Was that a hard sell?
You know, I had been suffering for so long, since the age of 13, that I was very desperate for any type of results. And so the second she told me she would have to do surgery, I was like, okay, let's do it. I'm like, pain medication wasn't working for me at this point. I had been to multiple GYNs before I met Dr. Rodriguez, who actually took me seriously. So that's also part of the problem. Even with the CAT scan that stated possible endometriosis, the GYN I saw prior to her told me that it was nothing.
So let's talk about that, this sort of delay to definitive diagnosis. Christine, you were talking about the age at which this is diagnosed, which is well into women's reproductive years. What's that delay about? Is it reluctance to do this invasive procedure to make a diagnosis, or is there more to it than that?
I think it's incredibly complex. And I think Allison brought up one point that her pain was dismissed. So there is a concept of dismissal of pain in young women and adolescents and older women as well. And the problem with endometriosis is that it's a condition that's characterized by excess estrogen. So in fact, their sensitivity to pain is enhanced by that excess estrogen that they have. So they are actually feeling very intense pain. I think in addition to the dismissal of pain, the lack of a non-invasive method for diagnosis is a major challenge for young patients and their parents, because that surgery to diagnose endometriosis is very invasive and can leave scars. So a lot of people put it off. And then there are a multitude of other reasons. With endometriosis, it's kind of a tricky disease. The intensity of the pain that patients feel does not correlate with the stage of the disease. So you could have very severe symptoms and have mild endometriosis, which is difficult to detect, or you could have very mild symptoms and very severe disease that could be detected when you have a C-section. And they never knew that they actually had it, or they're diagnosed with silent endometriosis when they're confronted with infertility, for example. So it is a very tricky disease that is not easy for the patients or the healthcare providers.
And is that discordance between the extent of the endometrial tissue in the pelvis not correlating with the level of pain, is that understood? Why that is?
No one really completely understands the pain of endometriosis. There are thoughts that there are nerves that line the area that are near these areas, and if they're impinged upon by the lesions, that causes pain. Those lesions are like icebergs. They grow into the tissue, not out of the tissue. So that's why sometimes they're more difficult to be seen. But when they grow in, you can't tell where they're growing to and whether they're affecting nerves or neurons or not. But the pain of endometriosis is something that is very significant.
Well, I guess that begs a more basic question, which is, do we know what causes endometriosis in the first place?
We do not.
Theories, but not like a known cause. We do know that it's the endometrial tissue, that it's outside of where it's supposed to be, but we don't even know 100% how does it get there. For some patients, it could be that it goes out through the tubes. For some patients, it could be that it goes through the blood. In some patients, don't even have a period, and they already have endometriosis when they're, before they get their first period. So it's difficult to know. I mean, Christine.
There's even neonatal bleeding theories that when young girls are born and they have progesterone withdrawal, they have a mini period, and they could have retrograde menstruation, which delivers some of those endometrial tissues to the pelvic cavity, which stays silent until they hit puberty, and that they could then be reactive at that time. There's other theories that the endometrial tissue is simply misplaced during development, and it's just put in the wrong spot, and it stays silent there until hormones start in puberty, and then the children start feeling symptoms.
And Allison, how old were you when your symptoms began?
13 years old. Very first menstrual period, I immediately began to feel pain. But I need to note that my mother also might have had endometriosis. So for her, she didn't know how to respond to my pain because it was something that was normal for her growing up. And so whenever I would complain about the pain, she'd think it was normal.
Carmen, many women experience cramping or pain associated with menstruation. Is there some threshold of discomfort or symptomatology that gets you thinking that this is something worthy of deeper investigation?
In patients, yes. In patients that you give nonsteroidal anti-inflammatory agents like aspirin, Motrin, Advil, in patients that you give birth control pills, in patients that you give other hormones, and doesn't appear to work, or it starts working and then it stops, it stops after it works initially, those are the patients that you get concerned about.
Okay. Mm-hmm. So you mentioned a couple of sort of symptom relieving therapies, nonsteroidal pills. Once a diagnosis of endometriosis is made, are there specific treatments for endometriosis that go beyond just kind of relieving the pain it causes?
Yes, they are. Actually, the best treatment for endometriosis is resection of the lesions, and then to have maintenance with medication, like medication that mimic some of the hormones in the pituitary gland, which is a little gland in the brain that tells the ovaries to stop functioning. Why? Because the ovaries, like Christine was saying, the estrogen is what causes the pain the most. And some of those hormones suppress the estrogen and suppress the ovary. And they can be used for that. Progesterone is one of them. GnRH analogs like Lupron. Those medications, the birth control pills, they prevent ovulation. And there are many formulations. You can have an intrauterine device or an IUD that goes in the uterus. So those medications. But the best is to resect the lesions for the pain and then to keep those medications from continuing the ovaries to have a cycle every month and produce hormones that will give you pain.
So by resecting, you're talking about more surgery.
Correct.
So,
but it's not the only option.
Yeah.
You can decide to treat without resecting them, but I'm saying that the most effective way of dealing with pain is to remove the lesions that exist and then continue the medication to help them. But there are patients that have disease that can do okay with medication.
I imagine that those medications also have profound implications for a woman's fertility.
Correct, because while you're on them, you're not ovulating and you're not able to get pregnant. And patients with infertility issues, they need to first get treated for the endometriosis at time, and then you're giving them hormones that make the endometriosis worse. So I'm sure Allison can
Yeah, so Allison, let's hear more about your personal experience with that. What treatment did you have and how did that affect you?
So we began with Lupron, and in the beginning, it was very helpful. But the side effects, which include menopause symptoms such as hot flashes, depression, I had severe headaches, then began to take a toll on me. Also, you don't menstruate, but you're still spotting throughout the time. So those began to take a toll on me. We switched over to Orilissa, which is, I guess, less intense as Lupron. And I was diagnosed with infertility at 23, so that was a whole other issue in itself for me. I did undergo fertility treatment, but to this day, I'm not able to carry a pregnancy because there's still liquid that we don't know where it's coming from seeping into my uterus.
Well, I'm sorry to hear that. Did you have surgery to remove some of the tissue?
Yes, I did.
Would you say that you've gained relief from your symptoms?
So my first surgery, I believe, was very helpful, but I've had 2 other surgeries since then. And like I said, endometriosis also causes other issues. It was affecting my kidneys at one point, and I was relieved from some pain for about 2 to 3 years, and then the pain came back. Things such as Tylenol don't help with the pain. I need something stronger. And now at this point, I'm also still having pain after 3 surgeries.
Wow, I'm so sorry to hear that.
Now, it's important to point out that the pharmacologic treatment, taking medications for this disease, doesn't affect the progression of the disease necessarily. Anything that's FDA approved, they're FDA approved only for the treatment of pain. They do not change the progression of the disease. The only thing that can help is surgery to actually remove it. And I think that's something that's extremely frustrating for patients and their doctors.
Sure.
Is that there is really a limited number of agents. So there has been one drug, the one drug that Allison is on was introduced in the last 15 years, one drug for endometriosis.
So Christine, clearly there's a lot more that needs to be understood about this disease and hopefully have that understanding translate into better treatments. So You're deeply involved in research in this area. Tell us a little bit about that research and how that relates to the conversation we've been having.
I co-founded the Research Outsmarts Endometriosis, which the acronym spells out ROSE study, which started in 2013, believe it or not. And I co-lead that with Dr. Peter Gregerson here at the Feinstein. And since then, we've enrolled over 2,000 subjects into our study, along with an amazing nurse coordinator, Margaret DeFranco, and her team, which I don't know where we would be without her. And we have actually focused on the two main problems that face females with endometriosis: the long delays in between the time of experiencing the symptoms and diagnosis, mainly due to the requirement of invasive surgery for diagnosis, and the lack of effective and tolerable treatments. And we have focused primarily on studying menstrual blood as a tool to better understand this disease. So many ask, why use menstrual blood? You know,
why use menstrual blood?
That's what everybody asks. Well, first, there are multiple reasons, but the first is that what Carmen actually pointed out in the first place is that the endometrium, those cells that are lining the uterus of women with endometriosis, is different from those without endometriosis.
Even the endometrial tissue that's in the right place, that's
Correct.
In the uterus. Okay.
In the right place, and that has been known scientifically for a very long time. Some people think that it's some communication issue with the lesions talking to the endometrial tissue. Others believe that there are other reasons for it. We believe that there's an inflammatory condition in the uterus that may be driving this in a subset of women. So, and that shed is menstrual effluent, which can be easily collected passively without any invasive surgeries. And then, of course, all females have retrograde menstruation, which means the uterus is not closed. When you menstruate out of the body, you also have backflow through the fallopian tubes into the pelvic cavity. 90% of women have that. That is totally normal. And you could say, well, maybe it's clearance of those tissues that's defective in women with endometriosis. Our hypothesis as scientists is that it's pathologically changed before it left the uterus, that there is some level of inflammation, perhaps infection, that's driving that. And there is a condition called chronic endometritis, which is inflammation of the endometrium, typically caused by infections, which is just as common as endometriosis. It affects 1 in 10. It is very poorly diagnosed. Only women having a biopsy in infertility settings would know that they have chronic endometritis. But we think that that is somehow linked. And studies have shown from Europe that those women have a 3-fold increase of going on to develop endometriosis when having chronic endometritis. So that's why we've been studying menstrual blood.
Yeah, so what are you actually looking for in the menstrual blood?
So the first thing that we analyzed in menstrual blood were these, what we call stromal cells, which differentiate under normal conditions to help maintain a pregnancy, help develop and maintain a pregnancy. And we are able to manipulate those cells in a tissue culture plate isolated from menstrual blood and show that that process is defective in women with endometriosis. And that had been shown with endometrial biopsies. It wasn't even a new observation, but never with menstrual blood. And we thought, oh, we have it. We have the diagnosis for endometriosis. But it's time consuming to grow those cells. We have to culture them. Then we have to do an assay. Then there's a downstream assay. It costs money. And in the meantime, new technology has emerged that we've been able to start using fresh menstrual blood to analyze right off the start. We don't have to grow any cells, and therefore we can analyze many cells at the same time. And we've seen profound differences between patients with endometriosis and those without.
Allison, are you a participant in this study?
I actually am. When I visited my urologist's office, I happened to see a paper for it,
So what has that been like for you? What's your experience been as a subject, a research subject in this study?
Well, they collect your menstrual blood once, and then you send that in to them, and after that, I guess they do their research. There's really no follow-up afterwards. I'm just glad to be able to participate in something that's going to maybe eventually help find another way to diagnose or whatever it may be to help women not have to have such a long period of time between their first menstrual cycle and diagnosis.
I'm going to take a moment to put in a plug for participation in research trials and to thank you for volunteering to do that. You articulated it very well, but I'm just going to repeat what you said, which is that most people who participate in research trials are doing it because they understand their participation will help others and may or may not be helpful to themselves. We all owe you a debt of gratitude for your willingness to participate and help scientists like Christine and doctors like Carmen kind of get a better understanding of human disease and how to treat it.
So, I just, since I myself had this terrible experience, I would love to save whatever person I can from having to go through such a long time of waiting.
So let me kind of pivot towards the future here a little bit and ask both Carmen and Christine where you see this field developing, what's coming, and how soon is it likely to arrive?
Allison was part of our original ROSE study, and we are now just received IRB approval for a clinical trial in which we enroll healthy controls who do not have any symptoms of endometriosis, and women like Allison was when she was 20, before she was diagnosed, and who are seeing a laparoscopic surgeon. So they're seriously considering undergoing laparoscopic surgery. And we ask them to send us their menstrual blood sample prior to surgery. And then they obviously undergo the laparoscopic surgery as part of their standard of care. And we receive their results from that and compare our results to that gold standard. We expect it might be a little bit different than our original study where we compared women with full-blown endometriosis to healthy controls, and that symptomatic patients may be somewhat different. And that's the importance of this particular clinical trial, is to gather information to bring to the FDA to do a pivotal trial in a much larger population to demonstrate the efficacy of screening. And I should also note that we really are trying to screen large populations for endometriosis, not necessarily diagnose it. I think screening is a better approach, and those women or young girls, adolescents who have a positive screen should be highly encouraged to undergo laparoscopic surgery to get their definitive diagnosis. And that's what we hope for. And there are many participants like Allison who have shared their samples with us without receiving results. And once we have the assays set up in a CLIA lab, we would be able to share those with the patients themselves. But until we're sure of our results, we're unable to share them. We're looking for people who have symptoms in particular. These symptoms are very wide-ranging and they're very nonspecific. So it could be a number of things. I think it'll be very important, for example, to educate our colleagues in the GI, in the gastrointestinal field, for example, where many of these young people start their diagnostic odyssey, and endometriosis isn't considered one of the possibilities. So many of them end up with IBS, irritable bowel syndrome diagnosis. And they try to change their diet, and they do that for a couple of years before they realize that that's not helping them at all. So there is definitely people with symptoms that don't always end up in the hands of Carmen, for example, getting their diagnoses.
So Carmen, what do you think the future holds?
I think this is an amazing study. I think it will be a game changer. I think that if this comes to fruition and it works, and I I have confidence that it will. I feel that once we have a screen, patients will be more willing, and parents as well, because I've had several teenagers that it's difficult to convince the parents, will have something more to hang on so that they can get their diagnosis earlier. And even though a lot of the medications that we give for endometriosis cannot sometimes in some patients stop the progression, like in Allison, we will be able to find it way earlier. When I first did the laparoscopy on Allison, she had so much damage and she was so young. And we were taught in medical school to look for patients in their 30s for the diagnosis. So if we go into like a 12-year-old and a 13-year-old and they're on medication, even though it may not stop it, but it will stop it for many of them. So that's what I feel the future holds. Yeah. I think a Rose study can give us a screening test that could help many, many, many.
Where else can women go to get more information about the things we've been talking about today?
I usually tell patients the Mayo Clinic, the American College of Obstetrics and Gynecology. If they want to read, they can definitely, those two are reputable resources that they can look and read about it.
As Carmen said, ACOG endometriosis FAQs, if you Google that, you would get the ACOG endometriosis fact sheet. There's
ACOG
also,
is the American College of Gynecology.
Obstetrics and Gynecologists. And ASRM, Endometriosis Guide for Patients, is also useful. I think if people want to get involved, the Endometriosis Foundation of America, or EFA, they just started an Up Endo Coalition involved with advocacy and education surrounding endometriosis. And they started a bipartisan congressional endometriosis caucus.
That's great. So, Allison, we'll give you the last word. Anything you want to add?
So they mentioned everything, especially the Endo Foundation. In the last few years, I found a lot of information through them, especially during grad school. I did a paper actually on the advocacy that they're doing.
Okay. Well, look, I want to thank all three of my guests today, Dr. Christine Metz, Dr. Carmen Rodriguez, and Allison Rodriguez, patient of Dr. Rodriguez. Thank you for sharing your insights and your experiences.
Thanks for having me.
Thank you for having me.
Thank you for having me.
For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.